All right, I'm Sally Bovey. I'm one of the child fellows here, and I'd like to introduce Vicki Lawyer Carlson. She's somebody that I met while I was rotating through Cottonwood, and I've seen her in action, educating people about family therapy, substance abuse, all sorts of topics in psychology and psychiatry. And I've seen her in action as a therapist, and she's really excellent. She has a private practice as well in town, and I'm constantly sending people to her. I don't know if you've gotten any, but I've been sending them your way. So she went to the University of Arizona for both her bachelor's and master's, her bachelor's in psychology, her master's in child development and family relations, and she has a PhD in human development and family studies from Oregon State University. She has many publications, has given many lectures, supervises trainees, and I hope you enjoy her talk today.
Well, good afternoon. Thank you for inviting me. It was quite an honor. Today we're going to be talking about family therapy for adolescent substance abusers. Oh, my screen went off. And what I'd like to do first is give you just the overview of what we're going to do today. And I'm not quite sure where everybody is in their knowledge of this area, so if there's an area that you want me to cover more, just indicate that, and that would be no problem. If this is something that you all know and it's like Psychology 1 for you, just nod that I should just go on, and that would be fine too. So I'm looking for feedback from the group to know how much to cover in what areas. So when we look at any of the literature in substance abuse in adolescents, there's basically 5 areas, and I've put them into 5 steps. First, we need to look at the healthy family systems, and we're comparing family dynamics with our expectations for families. Then we look at adolescent behavior and the parenting skills. Here we're assessing the adolescent's behavior, and we're looking at the social context for the adolescent. Then we have to look at the adolescent symptoms, and we're looking for consistency and distinctiveness there to see if we've got some oppositional defiant behavior, conduct behavior, or this is stuff that's changed radically. Then we look at family structure and interaction, and our job as family therapists is to move the family from power to connection. And we'll go over what kinds of family systems are available in the interaction, and how we'd go about moving it from a power-based system to a connection-based system. And then we're going to look at the family therapy methods, the opportunity for the family to use that new process. So first, the healthy family system. Step 1, compare the family dynamics with what you would expect in a healthy family with an adolescent. Now that seems like an oxymoron because most families with an adolescent feel a little unhealthy at times. Basically, and not for any particular reason, but I did the most common family structure that you'd see, or the most original. Everybody who's a teenager has had a mom and a dad. It doesn't matter if they're living together, if they're parenting together, or whatever, but we know that they came from a sperm and an ovum. So in this particular family system, we have, I'm just kind of putting it into a typical family system, mom and dad, 2 children, and so we already have a couple thoughts about what is happening in a family structure with a parenting system and a child system. The assessment of the family system is going to include the structure, who's in the family. Obviously, that was the most generic form of a family map that I could do. We have all kinds of blended systems. We have all kinds of ways that children come into the world. We have adoptions. We have surrogates. We have all kinds of stuff that could happen. So we assess in terms of the family, what's the parental subsystem look like? Who's the parent-child subsystem? What's the sibling subsystem look like? And then in terms of process, the early information is how is the information shared, who's entitled to what information, who interrupts who, and what's the level of emotional expression in the family, and who has what power. Okay. Simply what that means is you can, on your very first contact with the parents, or by looking in the waiting room, you can tell how the information is shared. Parents will tell you on the phone, I'm not going to tell them they're coming to a therapist. I'm going to tell them that we're going out for ice cream. believe me, it doesn't make for a happy session when the kid thought that they were going out to Target to get a CD and they end up in my office. So we look for those dynamics, and that's just the information to put in your head because you know kind of what you'd expect in a healthy family. And generally in a healthy family, you would expect parents to say, hey kiddo, we're going to the doctor's, we're going to talk about what's going on, and afterwards we're going to go to Target. So we're just looking for what that flow of information is going to be. And so then we start mapping in our own mind what's the family subsystem. Now, okay, the very basic piece of it is you expect the parental system, whoever is included in this, you expect the parental system to make the executive decisions. Parents decide if kids go to therapy or not. Parents decide if kids get immunizations or not. Parents provide food, clothing, and shelter. So there's basics that we expect from that parenting subsystem. And again, seeing the kids right in the waiting room, you can start making some decisions about who's deciding what and in what way. Are they having to trick the kid? Are they having to bribe the kid? All that sort of thing. And then we look over here. I'm not doing so well with this cursor thing. All right, then we look in here and we see what does the parent-child subsystem look like. Now we have some boundaries here. Okay, we have some boundaries here, and this should be a permeable line. That is, information should come from the executive system, go down into the parenting subsystem. So what happens is the parents say, you're going for therapy, and the child says, what time will I be done? Okay? So we're looking for direction. We're looking for who is the parent, who's parenting more, and who's the friend. Is one parent a parent and one parent a friend? How effective are the parents? So again, in terms of the healthy family system, parents make the decisions. They're responsible for basic food, clothing, and shelter. The boundaries are established to control information flow between parents and children appropriate to the developmental level of the children. Sometimes you have parentification going on where the parents are sharing way more information than the child's capable of handling. So again, as you can imagine, if a child is parentified, your chances of being able to intervene at a substance abuse level becomes really limited because somebody has to be in charge. Adolescence has privileges congruent with their increasing acquisition of skills, resulting in successful compliance with age-appropriate responsibilities. If you can't trust the child to make their bed and have breakfast, then you can't leave them home alone on the weekend. Sounds really logical, but that's not so for some parents. They don't make that connection. So they say, this kid is 17, I should be able to leave her alone. But if she's not able to, if she hasn't acquired the skills yet for basic tasks of daily living, for basic responsibility, then she's also not able yet to be unsupervised. This is an area that I see the healthy systems, they work well, the kid starts getting out of line, the parents go, this is a skill that this child should have, they tighten the reins, reteach the skill, and then everybody goes on. It's a steady process of the adolescent independence from parents as they take on more responsibility for their activities of daily living. So our job, obviously, with teenagers is to take them from people that we're giving direct instruction to mentoring them. And you can see that transition in a healthy family where when the child has the option of having a choice, the parents will say, I don't know, what do you think? And when it's a no-brainer, it's not a choice for the kid, the parents will say, you know, that's just not going to work out for our family. Okay? And you see this in general conversation that you get the parents and the kids to engage in. This is the stuff that we don't really have to do too much assessing on. We just see it. It's just right in front of us. Okay, families with adolescents, the adolescent development. Family must balance the adolescent's needs for independence and guidance. This is the one period of time that goes back to being toddler. If you remember in the toddler years, kids will cling to a parent when it's an unfamiliar territory. They will go out and explore, and then if something frightening happens, they will come back. But during their exploration phase, a competent parent is going to let them go and explore. What happens in adolescence looks the same way. Sometimes parents misunderstand that as not being needed. But the child will see something that they want to explore. They'll touch base with the parents originally, even if it's just to have a conflict. They'll look for some ways to get engaged with the parent. They'll go off. They'll try their things. But if their car breaks down, who's the first person they call? So when an emergency happens, they'll come back to cling to parents. So we would expect a lot of, I can do it, Mom, you need to help me with this. Okay? The adolescent's development of abstract cognitive abilities, specifically their personal fable and imaginary audience, increases their demands for parent-adolescent problem solving. This is a period of time in their life where they can think of more options than they've ever thought of before. It's a very exciting time cognitively. Again, they're back to the 2-year-old stage where their cognitive map doesn't fit everything that their brain can do at that time. So what happens is that they practice this ability to think abstractly in terms of arguing with us. They can, if you see a teenager come into the office and you have them tell them have a seat, they may sit on the floor, they may sit on your desk, they may sit on the chair. With a teenager, you say, have a seat in the white chair, because you really want to limit, because their brain is letting them sit anywhere. If an adult comes into your office and you say have a seat, they're going to have a seat in the white chair, because it's really obvious for adults. They just censor it right away. So the adolescent thinks that they are so unique that nobody could possibly understand them, but they also think that everybody is watching them and everything they do is transparent, which means for parents that I think you can read my mind and you just don't care enough about me to read it. And then I think you're wrong in what you're reading. So really, as a parent, you're kind of balancing, again, enjoying their personal fable, enjoying their imaginary audience, and knowing that it's not about you, that your kid feels completely misunderstood. My daughter, of course, at one point told me, "You don't listen to me." What kind of a therapist wants to hear their kids say, "You don't listen"? Just a perfect adolescent moment. Okay, the adolescent's immature system for problem solving is seen in an overuse of alternatives and an underuse of understanding the consequences. So adolescents test values and beliefs and attempt to derive personal meaning from influences outside of their family system, which means in all of their alternatives, this is where kind of the arguing back and forth, the grandstanding, all that comes in. It's really exciting to watch. It's all cognitive processes. What it also means is that teenagers believe other people can become addicted, but they can't because they don't want to. Okay, surviving the teen years. I don't know if you've ever seen this. Because teens are so preoccupied with the rapid changes in their lives, they tend to be forgetful and easily overwhelmed. And she says, I've got too many things to do, and I can't remember what any of them are. So we go in through the back door, because of course we're wrong in most of the things that we assume for children. So we go in the back door, we lead them out through ours. The way we do that, we transition our parenting skills. Skills used prior to the age of 11 are no longer sufficient to meet the demands of parenting an adolescent. Parenting success becomes more dependent on connection than on power. We need to understand how our adolescent is seeing things, knowing that they are very equipped in the alternative stage and that they're not as good through consequences. So what our job is to help them understand what the consequences are with them not knowing that we're leading them there. Okay? We do that by the parent maintaining the role of authority while providing an opportunity for increasing responsibility and decision making. That boundary maintenance prevents the parent from becoming friends with their adolescents. No 2 days are alike, of course. I heard this from one of the counselors at one of the local middle schools, and I loved it. I asked her, how do you deal with teenagers all day long? She says, once I thought about them as walking hormones, everything made sense. So I've adopted that. The family system response to an adolescent is flexibly connected. They're responsive to demands that sometimes require enmeshment, like crisis, and they're sometimes distant, like schoolwork. Okay? Now, the family system process. This is true for all family systems. The complementarity, for every action, there's a corresponding reaction. Okay? So in all families, what we want to see is, where's the complementarity? Sometimes there will only be one person talking in the room, but you know if mom and oldest sister are getting embroiled in an argument, there's some button being pushed in mom, there's some button being pushed in oldest sister. And if the two of them are arguing, then we can see where the other kids are fading out. So we look for complementarity just to fulfill that part of the puzzle. Triangles. Third persons are brought into a conflict between members of a dyad, becoming an obstacle to resolving the conflicts. There's no such thing as a triad in human relationships. It's always a dyad plus one. And whatever problem has to be resolved between mom and daughter cannot be resolved if dad steps in continuously. So we look for where the triangle is. We don't wonder if it's a triangle because it's human relations to be helpful. But we just look where the triangle is. Coalition, the child unites with a parent to become more powerful than the other parent. This is where we start seeing marital difficulties. If there's marital difficulties, you're probably going to be seeing coalitions. Scapegoats, the family designates a member to carry out and act out the stresses and dysfunctions for other family members in the system. And oftentimes, your drug-abusing adolescent is the one who's been elected by the family to carry out the symptomology. And approach distance patterns. All families strive for balance. So balance allows the closeness and the distance. And out of balance creates controlling, clinging, and stalemating behaviors. So when you see those, you know you're looking for something. Okay. So that brings us to adolescent behavior and parenting skills. That's step 2. Assess the degree of out-of-control behavior and the adolescent's social context. Okay. And here, what we're looking for is resources versus demands. And again, it's always about a balance. So, assessing the degree of out-of-control behavior. When somebody comes in with an adolescent who's using drugs, your first thing is you have to figure out how much danger they have to themselves, how much danger to others, and how different this is from past behaviors. Unfortunately, some of the drug use and some of the behaviors that kids are involved in eliminate our possibility for working with the family system first. Sometimes you have to protect kids from themselves depending on who they're associating with and what they're using and to what degree they're using it. So, in terms of parenting skills, this one has the boy on the couch. His father's looking over him. What? I did my homework. Well, most of it. Well, some of it. Okay, I haven't started yet. Dad says, I'm glad we had this little chat. Okay. Parenting skills, parental monitoring. People who monitor their children are less likely to have drug abuse problems. And the research is showing it over and over again. It's about monitoring. It's about being there. Again, with a toddler who's exploring, you wouldn't go, oh, they're exploring. I think I'll go have a coffee break. Right? You monitor. With an adolescent who's exploring, they think of more options than they've ever thought of before, and they don't know how to bring those options to consequences. Until they're good at that, you need to monitor a lot. Developmentally appropriate demands and responses. When a child is accomplishing one set of demands and they're good at it, then you can increase the demands. If they can't walk, you can't expect them to run. Consistent and authoritative versus authoritarian discipline techniques. Kids who are damned if they do and damned if they don't will. And so it's about, again, balancing so that the kid can find some way to please you. Children are hardwired to want to connect with you and please you, but you have to give them a door. Supportive parenting behaviors, current environment. If you have chronically conflicted relationships in the family, those children are higher risk. If you have pervasive expression of negative emotion, those kids feel anxious, they want to self-medicate. Quality of parent relationships is low bonding, low emotional disengagement. Kids will try to please somebody that they're connected to. Familial alcohol and drug behavior and attitudes. Sometimes a kid will try to get sober and their parent is currently using. That's really, really difficult for a child to get sober in a household where drug abuse or alcohol abuse is rampant. And in fact, I haven't seen kids be successful living in a household with somebody who will not stop drinking so their kid can get sober. And generally, parents, if they're not addicted themselves, will stop using substances so that their kids can get sober. So if you have a parent who says, I'm not going to let them control what I drink at dinner, you've probably got somebody with alcohol problems anyway. Parental attitudes towards an adolescent's drug use. Oftentimes we'll have, which I think is a little interesting, we'll have parents who get high with their kids and think of it as a bonding experience. Obviously, that contributes to drug use and really decreases our ability to make an intervention. So we're looking at demands and resources. So for kids, in terms of their resources, if they have an unhealthy family environment, if their school environment has success within it, they experience belonging and comfort, they have supportive counselors and teachers, they do better. If their peers have sources of entertainment that are healthy, their thoughts about authority are appropriate, and their home environments are safe, the kids do better. So again, it's all about balance. So if your child chooses an unhealthy peer and they're a healthy kid, and you have a healthy home environment and a healthy school environment, it's about balance. So your child can influence the other. If your home environment is difficult, their school success is difficult, and then they get up with some peers who are having a difficult time using drugs, then the chances of them using is pretty good. So then we look at the adolescent symptoms that we did. Okay, so that's step 3. We're going to assess for consistency and distinctiveness of behavior patterns. So what we want to know is this behavior new? For some kids, they've always been really well behaved, they listen to their parents, and then overnight they change dramatically. That's real different than a child who's been difficult since they were born. So this little Zitz comic, his friend says, I'm leaving now. The bathroom's a wreck. My homework's unfinished. I don't know when I'll be home. Oh, and I got a new tattoo. His friend says, you bury your bad news under other bad news? And his friend says, yeah, they can't yell when they're sighing, dude. Okay. This child coming home pierced probably will not be dramatically different from the behavior that the parents have learned to expect from him. Okay. So, consistency in adolescent behavior. How has the adolescent's behavior been in the past with the family, in school, and with peers? There are periods of times that we expect to see adolescents changing, trying things out. At 10 and 11 years old, the children have gone latent. Their peers are more important. They're sort of sitting back thinking about what kind of an adolescent they want to be. 13 and 14, they're testing out that peer structure. By 15 and 16, they should be transitioning to intimate relationships for intimacy versus isolation. So you should be seeing the behavior that's transitioning should be a little different than what you'd ordinarily expect. But because adolescence is such a period of time of so many systems changing on them, you keep in mind what you would expect to change with the family, school, and peers and what is changing. If somebody has had really nice friends their entire life, they hang out with great kids, they get good grades, and then over the course of a semester, their other friends don't want to hang out with them, and they've chosen new peers, and their hygiene looks different, that gives you information. Is there a behavior disorder to be considered? Things that I've been talking about. Conduct disorders, oppositional defiant, tactile sensitivities, sensitivity to change, chaos, that sort of thing. Sometimes children do really well in the earlier ages because the teachers know that they don't do change well. They know that they have a tactile sensitivity, and so the younger years, teachers are more sensitive to that, and the children don't have the same behavior outbursts. Transitioning into middle school, they lose some of that support. So if you know that a kid's had trouble with tactile sensitivity all the way along, you'd expect them to be having more trouble as they transition into middle school. Thank you. Is there a learning disability? Learning disabilities have a different impact at different stages of their school life. So you look at what you're expecting from them and what the disability is now. As you're noticing, I'm putting everything that I can into normative context because adolescent behavior is one of those tricky times when there's a lot of change, there's a lot of transition that we just expect. And normative parenting kind of gets the kid as they're going on the off-ramp, corrals them back around, and puts them back on the on-ramp. Okay? So normative parenting is going to catch lots of this stuff. What's the family's experience of patient's impulse control? Has the patient had violent tantrums throughout his or her life? Do people walk on eggshells around the patient so as not to engage the patient in negative behaviors? Sometimes you'll get a parent who is trying to discipline a child, and they will say, okay, I'm taking away your cell phone. The kid will throw a fit that doesn't match any other fit that you've ever seen, and they get their cell phone back. So you kind of look at what's their pattern of tantruming and how have the parents handled it in the past. Distinctiveness in the behavior. Has there been a change in behavior, and how long has that been occurring? And has there been trauma or loss? Duncan Stanton at one point had, in his research, seen that when kids start drug abuse, if you look back over 2 years, you will see a traumatic loss. There's a death, there's a divorce, there's a chronic illness. There's something that shook their reality of the world 2 years prior. So I typically look for whatever was in their family system that they were no longer able to count on. The symptoms of substance abuse above and beyond adolescence as a developmental stage. Isolation, lying, unpredictable behavior, depression and moodiness, changes in grades, peers, weight, hygiene, and odd agreements or secrets, and shame in family interaction. Now, all of these areas are things that you would see from the typical adolescent. But in family therapy, this is the piece that really speaks to you when just the mom has come in and the kid hasn't even been there. If that family is starting to do sort of like walking on one leg with their head cocked just to get things just right, then you know something's wrong in the family system. Families are programmed to establish homeostasis, and before they know what's happening, that theory of complementarity, the behaviors begin becoming very, very odd. And you just get that sense in your stomach that this isn't appropriate directions for things. Okay? So the stages of substance abuse and intervention. In early stages, there is substance use. It has not become an addiction, and the use is infrequent, usually 1 to 2 times per week, and there are a few other symptoms. As a clinician, your job is to adjust the parenting because you know those odd patterns have started up, so you have to readjust that parenting system, increase the boundaries, and educate. In middle use, kids are using daily. There's a physiological dependence, but there's no physiologic consequences or legal consequences yet. But the child is not successful at stopping their addiction. There you're using intensive parenting adjustment, teaching parents that everything in life is a privilege except for basic food, basic clothing, basic shelter, and that their child is not ready to be unsupervised if they are getting high every time they walk out the door. Enactment and therapy sessions to empower the parents and redirect the adolescent's power, and ongoing support for parents in the middle phases. In the later phases, you have a deterioration in health, legal consequences, higher tolerance, use to blackouts, suicide attempts, deteriorating mental health. There, typically, parents need intervention assistance. They don't have enough control over their child to get them into help. Sometimes they have to have an interventionist get the child out of bed in the middle of the night, bring them to a wilderness program, get their behavior started on the right track, bring them to an intensive inpatient facility. It's most likely inpatient placement and structured aftercare. It's about removing the child completely from that system because that system's not working for them. This is not parent blaming. Anybody can become addicted, and some of the drugs now, as you know, that people become addicted to, what used to take 30 or 40 years for an alcoholic to become addicted at that level can happen within a couple weeks, depending on what the kids are using and how they're using it. Complicating factors is the drug use accompanied by other disorders. More behaviors that are connected to the drug use, the more need for structure. So if they're in the middle stages of addiction and they also have an eating disorder, they have depression, they're cutting, then they need more assistance. If the type of drug they're using, if it's marijuana, it's one thing. If it's meth or crack or cocaine, then it's just a different level of intervention needed and a different level of risk to the kid. And how many unsuccessful attempts have they had at sobriety? Okay. So then we move in the family structure, and this is where the family therapist comes in. So everything up until now is really the assessment of how big of a problem do we have? Is there a problem? Is this normative? Can we just kind of toy around a little bit with the parenting structure and help them be more effective as parents? And I always tell parents, your job when kids are out of control is to bring those boundaries in so they can touch them, because your child is going to be out of control until they touch the boundaries around them. Not unlike an infant in a crib. The infant will slide up against the boundaries of the crib historically so that they can feel the safety of the crib. Adolescents will bounce up against the rules historically so they can feel safe. Adolescents don't want to be the most intelligent person they know. That's very scary, to be 15 and know more than the people who are supposed to be taking care of you. So they're going to bump up against your rules. So we need to move the family process from power to connection, because as soon as all of this stuff happens, the interaction starts in its own system getting more power-based. The kid breaks a rule, the parents come down hard, the kid breaks another rule, you can't make me, all that kind of stuff happens. So we're looking at process, not content. Family therapy focuses on the structural and patterns, on the structure and on the patterns of interpersonal interaction. Families use repeated patterns of behavior to meet interpersonal demands. The sequences are often outside of the member's conscious awareness. So it's kind of like when you get in your car and you start up your car. Most of us don't think, open the door, sit in the seat, put on the seatbelt. I mean, that first day when you first drive a car at the very beginning, you're thinking about all those things, but later you just jump in the car and go, right? The same thing happens for families. It's repeated patterns of behavior. So they just go into their typical patterns of behavior without really conscious thought about what's happening first and what's happening second. Repeated patterns can be seen as themes of adaptation. Is the theme that dad gets mad, mom gets crazy, youngest kid starts being hysterical, and all the pressure is off because everybody's soothing the youngest one? Okay? And then it's within the sequences that the symptoms are inadvertently reinforced. If the child can start a fight between mom and dad, they can slip out the back door and go off with their friends. Family therapists identify, challenge, and redirect the symptom-maintaining sequence. So in terms of family therapy, that's what we're looking to do. So identify the sequence, challenge it, because it's not that we have the right strategy, but we're like spin doctors. The strategy that the family's using is not working. So we take another spin and hand it back to the family. Different behaviors will lead to a different place. So, in some of your fields, it becomes more predictable. If you do A, you're going to get B. All we know is that this pattern isn't working, and we have to come up with a counter proposition to the way the family thinks things are going that makes sense to them, that gives them a new direction. So the initial adjustments in families with substance abuse. This is where the power base emerges. Chaos is created by the habitual use of behaviors in response to new stimuli. That causes confusion and protest. So if you think about attachment and how humans go to other humans to be soothed, okay? So animals will go to places for soothing. Humans will go to other humans. If your child acts out and you come to talk to them and say, hey, honey, what's going on? Talk to me. And your child tells you to F off, you're going to be confused and you're going to argue with them. Because you're going to go, hey, this isn't right. Then members start experiencing fear of an unidentifiable loss or danger. In their gut, they know something's wrong. They know this source of attachment, this connection that they have, is going away. They can no longer predict it. They can no longer depend on that safety, that prediction. So they experience anger and grief. What do people do? Excuse me. What do people do when they're angry or they're grieving? They argue, they fight, they become more intense because they're trying to get back whatever they're losing. And then members move toward detachment from the perceived source of pain. Once the attachment injury is in full presence and people can't figure out a way to get away from the pain. They say things like, I'm going to let her do whatever she wants. I can't stop her anyway. I'm not going to worry about it. Okay? So this is, if you look at any attachment injury, the first thing that's happening in families are really predictable behaviors based on an attachment injury. This is basic attachment for all humans. We used to think that attachment was primarily present in infancy, but it's throughout life. It just kind of changes its form. But the original need to attach to somebody else and to react with protest and clinging and anger to the loss of attachment is very real. Okay. Family therapy perspectives. Treatment is in family systems. Work involves the entire family. Now, obviously, sometimes you can't get the whole family, but it's your goal because every member has a part in the dance. Dominant approaches for substance abusing adolescents is structural and strategic. You want to move the systems back to doing what they're supposed to do. You want to give the parents permission to take the authority back in their family and the kids permission to be kids again. But we need to use strategic because we need to, in some way, use their proposition that they're already operating under and give them a new direction on it. We can't just take away their way of existing and hand them a brand new one. We have to go with whatever they're doing right now that makes sense to them, because people who don't know what to do go back to doing what they did best, and in this case it's not working. Then the symptoms are seen as related to problematic family functioning. In family structures, it's an inverted hierarchy where the parents are kids and the kids are parents. Over-involvement or under-involvement. And sometimes you hear that in the addictions literature as being called codependency. I think about it as attachment. Family interactional patterns that are particularly pronounced in these families: triangulation, conflict, and detouring. The person with the addiction is trying to get the attention off of themselves. So, family systems with substance abusing adolescents. You remember the last system that we had. Here's the dad and the mom. The boundaries here are insufficient between the parents and the children. And what you have, if this is the identified patient, you have the rules set by the child and imposed onto the parent. So the child will say, I am not going to a therapist's office. You can't make me. And you need to get me unlimited text messaging because this is ridiculous. Give me your phone. And the parents will do it. You know that this system has been completely inverted when the parents come and say, the way that I got them here is that I told them that I would get them a new phone, and I promised them they'd only have to come once. That'll be enough, won't it? Sure, I'm pretty good. I can get this done. Family interactions with substance abusing adolescents. Parent subsystems are ineffective, as we've talked about. Now, this isn't parent blaming. All of us parents, we do the very best we can. It's just that these things start getting into the system that reroute things. Parents are unable to gain compliance of the adolescent. The communication between parents and children reveal complex contingent rules. The kids, remember, they're great at alternatives. And the parents, not thinking that the children are just generating a whole bunch of alternatives, will try to answer each question that the child has. In adolescence, you don't answer any more than 20% of the questions your teenager asks you. The other 80% are just letting you know how upset they are or what's going on with them or whatever. So the other questions aren't really about what they're asking questions about. So you get that 20% of basic information that you need from the teenager. The rest is their brain kind of practicing what it needs to practice. So it's just entertainment. Parents may buy into adolescents' perspectives of rights and freedom demands. This is a tough part to reroute parents. We want our kids to have the best. We want them to have what they want to have, and we want to think that they're great kids. And so the kids will say, you don't have any right to call my friend's parents. Guess what? You do. Adolescent clings to entitlement, and there's a confusion between rights and privileges. There's a high expressed emotion in these families. Parents try to reason with the adolescent, tend to lose themselves and their authority by entering into bitter arguments with the adolescent. This is that part that you as a parent go, you know what, I've answered 20% of this. And I think what you're asking me is, am I ready to leave you and your friends on a vacation by yourself? And as much as I see all the reasons why you think we ought to, I'm not ready. That's the answer, no. Okay? So this high expressed emotion, if our child can get us in there arguing, then we do things that we don't like, we become humbled and embarrassed, and we make up to them. It's the goal of the adolescent argument, to get the parents to feel bad so that they can do what they want to do. And family balance. Members engage in increasingly more chaotic behavior to compensate for unpredictable behaviors. And again, you're kind of seeing the pattern in the talk. There's always that bit at the very end. Whatever's happening, it's about balance. So in families like this, we have to unbalance it and create a new balance. Complicating dynamics. Again, this is all about balance. Families with greater variability in multi-parent systems, like step families, or with an illness or disability, the parent is a substance abuser, the parent got cancer, the kid got a heart disease. In these families, the dynamics become more difficult because everything is about balance. And parents will maybe sabotage each other and create a loophole for the adolescent. Parents who can't talk to each other, and the kid will go to one parent and say, oh, you lived with mom, you know what a pain she is. And then they'll go to mom and they'll go, oh, you lived with dad, you know how hyper he gets. Okay? Adolescents may pit one parent against the other. Adolescent may be parentified and taking care of a parent. Parents may tell their kids, I don't know what I'd do without you. You're my only friend. Unintentional benefits of the adolescent staying sick. We know that there's a natural loss when our children become capable adolescents because they really don't need us until they need us. And so some parents unintentionally help the child stay sick. So what we do is we provide for the parents and the child a context for understanding their relationship. We educate them about attachment injury. We talk about the fear of loss and of attachment, and that it carries predictable responses of crying, clinging, and protest. We normalize what is happening in the family already that's so scary for them. The roles of the subsystems, we enforce proper alignment of subsystems to increase predictability in the subsystem and in the system. And so in that, again, I have a whiteboard in my office and I'll draw it out. And I'll go, look how crazy this is. How did you get to be the parent and you got to be so immobilized? This is what we need to do. And the children often are happy to be relieved of parental responsibility. Not immediately, but eventually. Reinforce basic parenting. You teach the language of no on the very first discussion you have with a parent. Everything in life is a privilege except basic food, basic clothing, and basic shelter. Converse tennis shoes are not a right. They're a privilege. Something covering your feet is the right. Okay? Process strategies. Now, in terms of families, we have basic human needs: power, control, connection, and affiliation. You can use any of these basic human needs that you want in families, but I have not yet been able to win a power struggle with a teenager. Just not done. They can go to lengths of behavior that just because I'm an adult would never go to. So when we're working, particularly with people who have, quote, nothing to lose, like teenagers, if we do power and control, we will lose every time. They're hardwired to connect with us. So we need to move that power strategy to connection. We reduce the opportunity for the adolescent to dismiss behavior that emerges from struggles for power and control. I'm not going to do what you tell me to do. And we increase the influence of healthy parent guidance through the use of connection and affiliation. We teach the parent to make it worth it for the kid using appropriate boundaries. So basic parenting. Identify the goal of misbehavior. Identify acceptable ranges of adolescent behavior. Offer adolescents a forced choice that always includes what they're currently doing and what will get them what they want. The reason you offer them what they're currently doing, you make the wrong thing hard and the right thing easy. And you can't win a power struggle with a teenager. So we don't want to win, but we just want to help them understand the difficulty with the choice that they have. So you can refuse to come home, and I can call the police and report you as a runaway. Or you can come home, and we can work on a way for you to be with your friends under supervision. They currently are not coming home. You can keep doing what you're doing, and this will be the result, or we can go this way. Again, remember, teenagers are hardwired to connect with you. They need you. They are not fully developed members of our culture yet. They need you. Sometimes they don't think they do, but you can change that. You can help them see that they do. So, again, with the zits, Jeremy, do you want to help us decorate the Christmas tree? No. Jeremy, will you please participate? No. It'll mean a lot to me personally if you'll just give us a hand. No. Would you prefer to teach me how to use Facebook or help us decorate the tree? Tree! So, behavior basics. Again, you won't win a power struggle with a teenager. All behavior is logical. Teenagers are hardwired through evolution to connect. Parents need to make the right thing easy and the wrong thing hard. So family therapy methods to do that. You have to increase the opportunities to use the new family process, whatever you're going to be doing. So your intervention with a family is literally in that first 5 minutes in the phone call when the parents say they won't come to therapy. And you say, tell you what, let's set up an appointment. And we'll say it's for all of you, but you come at least. And you tell your child that their choice is to not come, and you will make changes that make your life easier, or they can come and be part of the change. 9 times out of 10, the kid comes, because there is not an adolescent in this world who doesn't want to give their 2 cents worth. Okay? So you really want to capitalize on that thing that they want to have say in what's going on. Okay? So, the therapy. If it's outpatient therapy, individual family therapy, generally you're looking at weekly 50-minute sessions with a licensed marriage and family therapist or a similarly trained professional. First, you see the parents because you want to know what the scope of the problem is, you want to know the value system of the parents, and you want to do some parent coaching. You cannot redirect a parent very easily in front of a child because that adolescent already does not respect the parents. So what you need to do is work with the parents, get them on board with the strategy of hierarchy and how you're going to do this. And for parents who are particularly ineffective in parenting, you make a decision about how you're going to deliver that message in session that they need to redirect when their kid is there in a way that their kid doesn't know you've just redirected them. Make sense? So the first is with the family, because it's amazing how if you don't know what that family's value system is and you get in there and you find out not only do the parents not mind the kid using, but they use together and they buy it for the kid, it takes away your authority. So you need to know what's okay with the parents and what that family system is. The adolescents are seen second. You want to know from their view what's the scope of the problem. You want to know what the sources of motivation for treatment is. Where can I help you in your experience at home? Sometimes it's that they're grounded until they turn 91, and we can help negotiate for them. Sometimes it's that they want more use of their cell phone, they want more computer use. There's always some way we can help. We can get their parents to hear them. We can get their parents to listen to them. We can get their parents to work with them. So there's a lot that we can do to help the child achieve his goal or her goal. And then we need to assess the severity of the symptoms. Kids aren't going to tell us completely what's going on, but by taking a look at them, seeing what their eyes look like, see if there's any sores around their mouth, if there's any weight loss issues, how they talk about their friends, how they talk about their coping. It gives us some idea about what else is going on for them. So we need to see the kid in a way that we can really ask them point blank, how much are you using? How many times have you tried to stop? Then it's ideal if we could have a whole family system because, like I said before, with the triangulation and the coalitions and things, Having the whole family helps us see the rest of the story. And if we're going to switch, because families are homeostasis maintaining systems, if we're going to switch the proposition that the family comes in at, we have to see everybody and how they're responding to it. We have to make a change throughout the entire family system. It's possible without seeing the whole family system to make that change, but you have a lot more starts and stops because systems are very strong and they will bring that person back into line with whatever they're doing. So sometimes you'll get, like, mom and kid will come and they won't tell dad they're coming. Your work as a family therapist is to help them get to a place where they can tell dad that they're coming for therapy and invite dad in. Okay? You don't always wait. Some of the old schools were to wait until you could get everybody in, but if the family could get everybody into therapy, they might not need you. Okay, so sometimes it's about helping them develop the strategies that they need to get help before you can actually help them. When the kids are in the middle stages of substance abuse or in the late stages, generally they need inpatient work. I've worked with kids that I've told parents, I think that this substance use is really far beyond what we can do on an outpatient basis. I think you need to get the kid drug tested, and the parents are like, no, I trust them. Generally, as you know, with substance abuse, people end up falling hard. Eventually, it's going to be a hard fall. If you're at Cottonwood, say your child, you get the intervention, you get your kid into Cottonwood, and we get to Family Week, this is kind of like your extreme family therapy, essentially. First, you want to do the psychoeducational part. Adolescent development, parenting skills, addictions, and attachment behaviors. All the stuff that I've just talked about this hour. You want parents to know how it all fits in context. Then you look at the systemic place. We're looking to set up an experience during that week that's structural. We've got the whole family included, and we establish and maintain appropriate interactions and boundaries, and we facilitate that. If the child is speaking poorly to the parents, we redirect the child and we help the parents learn to say no. And then we get the experiential piece, and that's called the list work, if you've ever heard of that. It's effective communication skills that are taught and enacted in a facilitated exercise, and it's done in the context of a multi-family support group. So there's multiple families around, say 3 or 4 other families. The individual, the child, and the parent do the work in the middle, and then the families give them constructive feedback on what they've seen, heard, and felt. We also make sure that we generalize that learning. So the education is on Monday and Tuesday. The list work is on Wednesday and Thursday. Thursday afternoon and Friday are experiential. They're going to go to rocks and ropes. They're going to do equine therapy. They'll do a challenge course. Things to help the family use that new proposition, the counter proposition that the therapist has just given them, and use it to enjoy their child and for the child to enjoy them. Lastly, there's multifamily groups that we have right here in the community, and generally you're going to want individual therapy for the child at the same time as these multifamily groups that's focusing on the addiction and on recovery. It provides an opportunity to connect with others who are experiencing similar challenges. So for instance, again, you have the Cottonwood Family Week. The MARC has groups for adolescents and for adults. In Balance Ranch Academy has a facility for teen boys, and then they also have an intensive outpatient. And Colorado, they have a wonderful program called Families at 5. It's just a really neat model program for family recovery. And everywhere there are 12-step meetings. And families sometimes forget that the drug abuser needs recovery, but so does the family. Family recovery is essential. If the family doesn't recover with their own 12-step sort of behaviors where they are owning their own thoughts, feelings, perceptions, they're not trying to control others, they're not trying to get into somebody else's recovery, then the family system can't get corrected. The multifamily groups provide safety in reaching out, feedback rules for the group, ability to share experience, strength, and hope, and able to hear feedback from others who are outside of the current family system. I don't know about your teenager, but mine hears feedback. Will hear feedback from somebody else a bit better than she'll hear it from me. So it's always helpful for another teenager to give feedback or another parent. And it can be used concurrently with individual and family therapy. And then I give you some references that I used for this. And that's it.